with children, youth, and families through the pandemic. And a number of those webinars focused on virtual care and acknowledged the fact that we were all transitioning to virtual care quite quickly, not all, many people. There are some experts like the ones we're going to hear from today who've been doing this for many, many years. But really, one of the areas of need has been around how do you work with those really, really complex high-risk situations, knowing that we want to do our best to support children, youth, and families during this very difficult time. So just before we get going, I'm going to go over just a couple of housekeeping notes. My colleague Tracy McLaurin is available online. If you do have any technical issues, please do let her know. Her email is in the chat, and she is also available to answer any questions. Please keep your cameras off and your microphones muted unless we call upon you, as this is going to help us to minimize the background noise. Please feel free to type your questions into the chat box. I'm going to be moderating the questions for panelists, and we'll do my best to bring all of your questions forward. We may actually unmute you if we need a bit more information, and would invite you to round out your question if necessary. And following the webinar today, you'll receive an email with a survey link to give us your feedback. We do use this information to plan future sessions. In fact, this session is the result of much of the feedback we've gotten previously. So please do take a few minutes to fill it out. It doesn't take very long. It's only about 5 questions. So I'll start by recognizing the history, strengths, and diversity of Canada's First Nations, Inuit, and Métis communities. We are committed to engaging respectfully with Indigenous children, young people, and families within and across nations in what is known as Ontario. We here at the Centre are here in Ottawa, and Ottawa is the traditional unceded territory of the Algonquin. What I'd like to do now is introduce our panelists. Dr. Darren Courtney is a staff psychiatrist and youth addiction concurrent disorders service clinician scientist at the Cundall Centre for Child and Youth Depression at CYMH. Darren earned his MD in 2004 at Queen's University and completed his psychiatry residency in 2009 at the University of Ottawa. He was the clinical director at the youth inpatient unit at the Royal Ottawa Mental Health Centre for a number of years. And while working in Ottawa, he was highly engaged in postgraduate education and won a number of teaching awards for his work. He then moved to Toronto in 2014, where he worked on the concurrent youth inpatient unit at the Centre for Addiction and Mental Health, and has moved to outpatient work in order to pursue a career in research, which he'll talk about today, and the implementation strategies to facilitate evidence-based care funded by the Cundall Centre for Child and Youth Depression. He has an interest in both psychotherapeutic approaches and psychopharmacological approaches for the management of adolescents with complex mental illness. So welcome, Darren. Our second speaker is Allison Crawford, Dr. Allison Crawford. Allison is a psychiatrist and the Associate Chief of Virtual Mental Health and Outreach at the Centre for Addiction and Mental Health, and is also Associate Professor in the Department of Psychiatry and at the Dalla Lana School of Public Health at the University of Toronto. She is the Chief Medical Officer of the Canada Suicide Prevention Service, the Medical Director of the Ontario Psychiatric Outreach Program, and the founder and co-chair of ECHO Ontario, an award-winning virtual community of practice. These activities advance access to mental health services with a focus on suicide prevention, community-based care, and Indigenous wellness. Allison also has a PhD in English literature and leads the Health Humanities portfolio in the Department of Psychiatry. As the founder and scientific director of Heart Lab and editor-in-chief of Ars Medica, Journal of Medicine, Humanities, and the Arts, she also brings an arts-based research approach to her work in community engagement, research, and knowledge dissemination. So clearly we have a very, very skilled set of speakers for you today. In terms of the process that we used to plan for this session, as with many of our webinars, when you registered, we invited you to share your questions with us, and we took the hundreds of questions and we started to group them together. And so what we'd like to be able to share with you today is, because there were a number of common sorts of issues and questions that people raised, we're going to talk first quite a bit about clinical practice and how do you actually deliver care to children and youth with complex needs. Then we'll talk a little bit about the organizational considerations that you'll need to be aware of as you put these kinds of services in place in your organization. Also, really important, the professional and legal requirements when delivering this kind of care. As well as system level considerations. So how do we make sure we're delivering this care consistently across the province so that children, youth, and families, regardless of where they live in the province, are experiencing the same level of high quality care? And then finally, we'll wrap up by hearing a little bit about what the evidence has to say about virtual care for complex children and youth with complex issues. And again, a lot of this stuff is emerging as we are learning lots and lots through the pandemic and our quick shift to virtual care. And so really excited to hear about the work that is ongoing, but also the work that both Darren and Allison have been involved in their own labs during this time. So without further ado, I will actually shift over to some of the questions. Again, first, we're going to be focusing on clinical practice. And one of the big questions, Darren and Allison, was around all of the things you need to put in place as you're preparing to deliver virtual care to young people with fairly complex needs. So around planning and support, can you talk a little bit about what emergency or safety planning is required when people are delivering care virtually to clients who have complex needs? Really, really important sort of foundational piece of work. Maybe Darren, can I ask you to get us started?
Sure. I think this is a great question. My microphone is playing tricks on me right now. Okay. So I think a big part of this is just setting things up in the right way. So I really think it's important that we continue to see these youth. It's definitely going to reduce their risk to continue to be seen, whether it's virtually or in person. So I think it's really important to kind of prioritize that over concerns around the risks involved with virtual care. That being said, I still think we need to carefully think about how we're delivering virtual care. So there's lots of setup that can happen. At CAMH, what we do is we make sure we know where the person is going to be, what the address is, which address they're going to be at. We also want to know an emergency contact if there's some sort of crisis that starts to occur throughout the appointment, that I have someone else to call. Those are the two biggest parts. I also want to think about, are they in a private room? Are they comfortable sharing information that might relate to risk assessment as well? So a lot of it goes into kind of planning for contingencies. Another contingency to be aware of is what if the video cuts out, or what if the sound cuts out? You want to have a phone number to be able to contact them and follow up. Or if they suddenly go away from the picture and you're not sure what's going on, you need to have some ideas about what you're going to do next. I haven't had to use these strategies, like the contingency plans, very often. I can think of maybe one instance in the past year where I've had to do that. So I want to reiterate that it's pretty rare that we use these, but important to have in place in case there's issues, for sure.
That's great. Darren, Allison, did you want to add anything to that?
Sure. I mean, there's so many different directions, but as Darren was talking about these very important things, and I would agree, like just on those basics for sure. It really highlighted what we realized, even as a large organization early on in the pandemic, is the need to have an institutional policy. So these things sound very straightforward, but you need everyone to know them. You need them to agree on them. People need training in those things so that they are second nature, and so that they can be communicated to the client and their family. Because some of these things that we think of as very standard around safety can seem punitive if they're not communicated to all clients and families and at the outset. So something like, for example, when Darren was talking about verifying the address that they're at, verifying a phone number and a backup phone number, telling clients that they need to stay in the same location for the duration of the appointment. Like, you don't want them hopping in their car, and it has happened. It may have happened to you. All of those things, if you address them up front, and also, if we become concerned about your safety, this is what we do with every client. So if you have a policy, you can have a communication strategy. And if you have a communication strategy, it's going to seem less punitive or reactive, and letting clients know ahead of time. So, and there are lots of other things I could talk about, but that I think aligns with what Darren said.
That's great. Thanks so much. And again, we're going to probably get even more deep into those areas when we talk about organizational and system level supports for these kinds of services. Despite that, despite the best laid plans and despite the fact that you have all these safety considerations taken care of, what do you actually do if you have a young person who expresses suicidality or who expresses some kind of self-harm? What do you do in those situations when you're not right in the same room as the individual to try and intervene?
So I'm not sure my approach has changed too much for virtual versus in real life. My risk assessment is very similar in terms of understanding what are the risk factors, what's modifiable risk factors, what are some treatment plans we can put in place, what are some extra supports we can put in place. One of the research projects I have done is appraised clinical guidelines on self-harm and suicidality in young people. And we found that the NICE guidelines are high quality guidelines that you can refer to. So if you're looking for a document to kind of really kind of set your feet in good grounding, that's a good one to go to. The NICE guidelines are out of the UK and they're available online for free. And so I think it's really important to kind of just be confident that the same skill set that you're using in real life, you're going to apply to the virtual setting. It's pretty rare that I need to address something in this moment. Again, having those contingency plans, if there's an active suicidal plan or they're actively self-harming in the middle of your appointment, that's really important to have in place. Otherwise, my assessment and management plan is very similar. One of the benefits of virtual care has been that I can see people more frequently. I can do 5-minute check-ins with them. I can call them if they're not showing up to their appointment because they're taking a nap or what have you, right? It's easy. Their parents might be in the same house. They can just take their phone to their parents and I can get collateral pretty easily. So it's actually been, in some ways, the assessment's a bit more complicated because you have this strange window in which you're doing the assessment. On the other, we also have access to more information on some level as well. So it's been an interesting process as time goes on.
So on the note of parents, just wondering, unless Allison, did you have anything to add to that area, just around suicidality and self-harm?
No, the only thing I was going to bring up, two things actually, working on the Canada Suicide Prevention Service. So many of our responders are, they're volunteers and they may not have formal mental health training. And I think one of the things they have found difficult, because they do risk assessment all the time, is they used to work all together. So not only are they connecting with people virtually through phone, text, and chat in this case, but it would apply to video too. Not only are they connecting with them virtually, they used to be in contact with each other and sitting in the same location so they could reach out more easily. So again, that team-based notion and finding it's not just workarounds for working with a client, but how are you going to work with each other and get backup and support? And, you know, often you're in a room and you're like, can you please go and call the family doctor, or can you please go? And so you don't have that, and having that workaround, I think, is really important. And maybe we'll get into this discussion, but the other thing that popped into my head was the difference between working with a client virtually, where you already have an established relationship, and working with a new client virtually. And I remember literally 3 months before the pandemic at CYMH, we were putting in place a policy where you can't see someone for the first time in their home. Well, that just went right out the door with the pandemic. But for that very reason, because how can you assess appropriateness and safety of their setting if it's just a bit harder if you've never worked with someone before. But anyway, we're all navigating that.
That's right. We're all in this together, right?
I would just add to that is that, so in our department, we've actually set aside time for multidisciplinary meetings where we are talking about clients. We're kind of doing those hallway consults because we don't actually do them anymore, right, in real life. So we set aside time to do that. And I think that's been really helpful as well.
Great. And again, I'll probably come back to that to go a bit more deeply in the organizational considerations portion. On the note of, you talked about, Darren, one of the good things about seeing young people virtually is that you have access to their circle of support. What do you do if you have a young person with a parent or caregiver who has limited capacity or cognitive or some kind of cognitive impairment? How do you work around, work with the challenges related to that?
Yeah, I think that's a tricky situation, regardless if it's virtual or in real life. I think it will depend a lot on terms of what's the child's capacity or the youth's capacity. To what extent can they reflect and self-manage their own care? Certainly, if there's, I'm concerned about welfare risks or neglect or safety risks, I might involve Children's Aid at some point. That being said, I want to make sure it's not an automatic process, that's something that might come with a discussion with a multidisciplinary team. Fortunately, in our program, we do have social work support that can work with caregivers who are also struggling with their own mental health issues, not necessarily to do therapy for the caregivers, but to guide the caregivers on how best to support their youth. And so I think that's a really key part of doing this type of work, is having that kind of support, not just of the one person, but of the family system as well.
That's great. Thanks. Allison, anything to add? Okay. No pressure.
I was looking for my mute button. Yeah. No, I think that makes sense.
That's great. Okay, so even before we get to the point of actually delivering service, I think one of the key things people want to know about is, how do you assess whether virtual care is appropriate or not? And so can you speak to, there is an emerging body of literature in the children and youth space around for whom is virtual care a really good fit and for whom is it not a good fit? And when you're talking about young people with particularly complex needs, how do you know when it's appropriate or not?
I might ask Allison to start this one just to switch it up, and then I can fill in after
That's
that.
Great.
Throw me the easy one. And you notice, Pranima, that I keep pulling it back to the institutional, and that we'll toggle back and forth with the clinical. This is an area I think we are all challenged a little bit right now, because the regulations around the delivery of telehealth are really left with the practitioner. And even then, I can speak most from the medical perspective, but even then, they're really not very clear. So you can go to the College of Physicians and Surgeons of Ontario, and you can go to Saskatchewan, you can go to, anywhere else, and they vary, they're uneven. It is left to the practitioner to determine ultimately, from a medical legal standpoint, who is appropriate for care. So that means, as a physician, they have to be able to consent. So I would say that's number one. And in the case of a child, obviously assent if they're younger than 12, and the parents need to consent for them. And then in between, different people will say different things, but anyway, consent for sure. So if they don't know that, the pros and cons of being in having a virtual assessment or appointment, and they can't consent to it, then that is an automatic no, that it's not appropriate. All diagnoses are appropriate though. Like, there are no contraindications to using virtual care. So we used to say early on, like, oh, well, if someone has psychosis, or if they might be intoxicated, or if they might be, no, you just have to assess that as part of your consent process, and whether you feel that you can get the information necessary. And sometimes that also has to do with, are there team members available on the patient end? So I'm thinking of something like alcohol intoxication. You might need to know that in order to prescribe medication or do a complete assessment. And you might not get all the information through a virtual medium. So it might not be appropriate if you can't get it, but if you can work with someone on the other end, then it might become appropriate. So it's really just like, do you have the information that you need to do what is required of you in your scope or in your role? And can they consent? Those are the main parameters around appropriateness.
That's great. Thanks, Allison. Darren, did you want to add to that?
Sure. I mean, my experience recently has been I'm seeing pretty much 97% of my clients virtually right now. And these are high risk clients who have chronic suicidal thoughts, self-harm, substance use. That's certainly, I feel comfortable doing it. And as time's going on, we're kind of forced to use even phone call appointments, and I'm getting comfortable with that as well. So there aren't very many contraindications. The few instances where I see them in person, I have one youth who's just refusing to see me online and would rather see me in person, and he's relatively high risk. So, and his parents are willing to drive him in, and we get all gowned up in masks and face shields and everything, and he prefers that to video. And then the other few that I see in person is because I need to get their blood pressure and monitor their blood pressure, or I need to give them an injection or something like medical that I just obviously can't do online. But it's very much virtual heavy at this point in time.
That's
very
great.
few people that I can't think of an instance where I've turned someone away necessarily.
Right.
Yeah.
Right. That's one of the messages that keeps coming back, is that, rely on your clinical skills and your expertise as a clinician to assess these situations. And if it's at all possible to do virtual care, it's possible to do virtual care, right? In the absence of those sort of special requirements that make it so that you have to be in person with someone. So when you get the young person on your screen, let's shift a little bit to assessing their care needs. Are there any best practices that you can offer to keep in mind when conducting assessments in high-risk, complex situations when you're doing that kind of assessment virtually? Allison, do you want to start with this one?
So in other words, like, how do you do parts of the assessment?
Yeah, are there best practices that you should keep in mind in terms of actually doing an assessment? Are there things that people, I think, are asking for tips or suggestions, or is there anything unique about actually doing an assessment virtually that is different from doing an assessment in person?
No, I think what comes to mind, like there's so many different takes on that question. What does come to mind for me is, when we perform, let's say we'll call it an exam, but we're all constantly observing, making judgments. I have in my own mind flagged what's already more challenging to do in a virtual setting. So for example, looking at someone's movements, it's much harder with just the virtual and when you can't physically engage with them. So I know that if I have somebody who has a medication side effect and I have to look at their movement, that I might need someone on the other end, or I might need to think through how I'm going to do that exam and enlist the person on the other side. Same thing with assessing, people's, I had an example very early in my career, actually, where in my career in telepsychiatry, when I was meeting with a client near Sioux Lookout, and at the end, we wondered if he had a prodrome of psychosis, and did the assessment. And I thought, I don't know, it's not adding up. He seems fine. And then the social worker came back in and said, what did you think of his rapping? And apparently he was like this the whole time. And I just thought it was the line. So you need to know the information you need to, and we all have our routine ways of collecting it. And what are the things that are like a little more challenging to do virtually? I think it's pretty much all possible, other than like, Darren was talking about with taking a blood pressure, for example. You either need to meet with them in person, or you need to involve someone on the other end, or have a home device, or if you're going to take someone's blood pressure all the time, is there a device they can use and integrate other technologies in? So I think it's a matter of adapting,
right?
Having confidence, I think. And
that's great. Anything to add to that, Darren? Anything that we should keep in mind when we're doing virtual assessments versus in-person assessments?
Yeah, so I like to do my initial assessment. I like to do with the caregiver and the youth present initially, if the youth is consenting to doing that. And sometimes what can happen is the caregiver can start overtaking the conversation and start listing off all the negative things that are going on with the youth. And then the youth shuts down or gets agitated. And I do think that the management of that does feel a little bit different in virtually versus in real life. In real life, I can use the physical space to kind of maneuver things. in virtual care, you're kind of like, if they're talking over each other, I'm not sure if even if I yell louder, they're not necessarily going to hear me, right? So I do think it's kind of like being kind of thinking about that ahead of time, setting the stage. So a big part of this is just kind of saying, okay, I'm gonna ask you these questions. And if I'm talking to your caregiver and you want to interrupt, you're allowed to interrupt. I kind of like empower the youth to do that. I let the parent know that most of my questions are going to be directed towards the youth. I want them to answer first. I don't want you to fill in the gaps until I ask you to, just to kind of like set the stage so that it doesn't end up with that dynamic, which it can be a bit harder to control in the virtual care setting.
So ground rules are really important, and setting those things up in advance is really important. What do you do when you can't sort of see what's outside of your screen? So if you can't determine their physical presentation, if somebody could appear from here up to be pretty okay, but then you don't know that you can't really tell what's going on under here with their hands and their legs and that sort of thing. How do you manage those things that are off camera? And knowing that when you have somebody in front of you, you see their whole presentation, you're aware of other things in the room. Any advice on that?
My own experience, I've had a few situations where I was doing a therapy, and then the person's in their bedroom, and then partway through, someone gets up out of the bed behind them, and they're there. And I was like, okay, they've had the whole spiel about make sure you're in a private space and everything like that, but sometimes they don't necessarily know. So certainly it's a risk. Certainly the consent process does involve kind of like letting people know that there's certain limitations to this, and try and make sure you're in a private space and do the best you can. But there's sometimes there are surprises. In terms of doing what you can to prevent them is ideal. Sometimes there's so many things that could be happening that it's hard to manage all the time. But
you have to roll with it.
I think so, yeah.
Yeah.
A lot of unexpected things, I think, get thrown at us. But I agree with Darren, like having some kind of script, not that you read from, but like points, or even we hand out patient like tips for people ahead of time. And I think going over privacy and why, like talking to people about why we emphasize privacy is really important. And even like problem solving or troubleshooting with them. Can you talk in the bathroom? Can you wear a headset? Can you like helping clients to achieve privacy? And I'll always will ask people, I really need to know everyone who's in the room. And I will tell you everyone who's in my room.
Yeah, this individual did have headphones in, which was kind of like a good
just
right. So so it was helpful just to kind of like set the stage for headphones are ideal. Yes.
Yeah.
And Purnima, just to your specific question, if I wanted to see the whole person and I couldn't, I would ask them. And same thing, I will often check in with people because, right now, if you're going to do therapy for 45 minutes like this, it can be pretty intense, and would the person prefer to like sit in a chair like slightly off camera? Do they want me to back up?
Right.
You can check in on people's comfort with the angle and framing.
That's a really important point that came up early on in one of the early webinars around just organizing yourself and thinking about scheduling, because when you're on the screen, you have nothing else to pay attention to. So your entire attention is on the individual, on their facial cues and their voice and that sort of thing. And so I would imagine that that's particularly intense when you're dealing with a high risk or complex situation, right? So something additional to keep in mind. Moving sort of a little bit more to the fact that I think, we're all committed to ensuring evidence-based service delivery. One of the questions that came up is, are there any interventions that are particularly well suited to providing virtual care to high-risk children and youth with complex needs? Any kind of evidence-based practices in particular that people should be looking at?
In terms of the evidence base, maybe Allison could talk more about that. I can talk more about our clinical experience of running groups online. So I run a CBT group for adolescents with depression and a DBT group for youth with concurrent disorders. And both of them have been going reasonably well. Our attendance has maybe been even a bit better, partly because people are coming. They don't have to travel too far. There's various levels of engagement. Our DBT group, the young adults, seem to do really well with it in terms of engagement. They're using the chat as well as discussion, and they're validating each other over through the chat. And it's kind of like this. So some levels, I find it even richer than what we were doing in line. In real life. The CBT group tends to be, so they're more depression focused. So they're a little lower energy level, a little bit more me doing kind of like a webinar like this, as opposed to like a discussion necessarily. But it's been an interesting experience. And I've heard that from other people as well, that they initially, when this was all starting, people were like, oh my gosh, I have no shows. Everyone's coming. And it was kind of like this interesting process. So I've had some very positive experiences. One thing to be concerned about is the equity, right? So some people don't have access to virtual care. So those people don't have access to the groups now, and then it creates this whole kind of concern as well that we're trying to pay attention to. Or some people don't have the bandwidth to have their video on the whole time, and then we have some people on video, some people not, and what do we do with that? And it does create some complications.
But it's doable, I think, is what we're hearing, is that evidence-based service delivery is doable as online, virtually, the same way that it is in person.
Yeah, it took several months to kind of get at the infrastructure and policies sorted out to start doing group individuality. Somebody put a comment about privacy, so we have a whole consent process around that, acknowledging that we can't fully guarantee privacy in this situation. It does work well, I think, with skills-based therapies, where we're not asking the patient to share a lot of deep personal stuff necessarily. We're trying to teach them skills, and and they might bring that into their personal life, but it's not like heavier stuff that you might see in maybe a process group or some other type of group therapy. Yeah.
That's great. Allison, anything to add?
No, just that I think what the examples Darren is giving or showing, like, we're really pushing the boundaries right now. And I would say the evidence is very good for virtual care, even prior to the pandemic, for diagnosis and for pretty much basic interventions in all mental health categories. But I think we're gathering new evidence around groups and how they best work. The one thing I would highlight for groups is the extra work you have to do around privacy and ensuring, so letting people into groups, for example, having a protocol where people have a password and then they go into a waiting room and then into the group, and that you have a confidentiality process for, because other people in the group can easily record. So it really does increase the level of trust necessary across the group. And I know Darren knows this because I know he was involved in developing the group guidelines at CAMH. But
that's great. And I'll use this as a plug around virtual groups specifically. We actually have an evidence brief that's currently in translation, so it's almost ready to be released. Just capturing, and again, the evidence is growing in this area. So we've gotten a handle on what does exist, and we've also looked to the in-person group therapy as well as the adult literature to try and inform some of the work that's going on in virtual care for group virtual care for children and youth. But again, the knowledge base is just emerging right now. On that note of privacy, so just to highlight Greg from Phoenix Center, thanks Greg for your comment. One of the strategies that Greg and his team uses when there might be somebody who enters the space off camera and the individual that's receiving care might not be comfortable sharing, using hand signals. So establishing that in perhaps some of the protocols or sort of in terms of some of the preparation that you do, establishing some sort of signal. Touch your mouth with your finger means somebody's there, so I can change the conversation to light material that's not personal, and then they can touch their ear when it's all clear. So thanks for sharing that, Greg. Back to, sorry.
That, Purnima. Can I add one thing to what Greg was saying? Because I think that's a great point, Greg. Even around safety, there is that new kind of hand signal if people feel like they're actually in danger. And I think that's a really good thing. Maybe not kids who are too young. Darren could best answer that, but that's a good thing for clients to know, like how they can signal to you, not just if there's privacy or not, but if they feel in danger. And it's widely available online. It's the tucked thumb signal.
Okay, that's great. Great to know. Thanks, Allison. So back to the sort of conversation about interventions specifically. The question is virtual care appropriate for all concerned? So for example, autism, ADHD, eating disorders, high anxiety, and other comorbid mental health challenges. Can you do virtual care? I'm getting the sense that probably the answer is yes, but I want to give you a chance to respond with any kind of caveats there. It's okay to do virtual care all around.
So I've done virtual care with each of these conditions that you listed. Certainly is going to be challenges, right? With eating disorders, we do want medical kind of assessments going on at some point. With autism, if you're going to make any sort of diagnostic, I'm not sure if anyone on this call is a diagnostician, but some people will want to have an in-person session. I think the ones at CAMH are still doing some in-person stuff to do diagnostic assessments for autism. So there's going to be certain components that you might want to do in person, but for my usual standard care, all these things I'm doing virtually right now.
Okay, great. Allison, anything to add?
Nope. Just do it, try it. And the other thing is, if it doesn't work, you can always say, look, I really need to see you in person. Yeah. But you can use that mixed model and try it out.
That's great. That's great. So a slightly different question, but sort of a more expansive area, trauma. There's a question about, is trauma amenable to virtual, like treating trauma, is that amenable to virtual care, or should that be reserved? Is that like the one type of area that we should reserve for in-person?
So my own impression, so certainly in our clinic, we see a lot of trauma-related mental health concerns. Dissociation, self-harm, those are some of the concerns that we might come out of kind of addressing trauma or having people talk about traumatic experiences. And I can see where there might be some hesitancy. I do think it kind of does, if you follow kind of the typical strategies of making sure they have strategies to manage if they are dissociating, making sure they have strategies to manage if urges to self-harm come up, so that, and being pretty comfortable with those strategies prior to going into traumatic experiences, I think would be really important. I do think the threshold might be a little bit different if you are going to engage in this to kind of bring someone in person. That's my own impression. A lot of the trauma work that we see in our clinic, the social workers end up doing as opposed to myself. And I think they're doing some level of it, but maybe not as intensely as they were prior to COVID. Allison, what are your perspectives on this one?
Yeah, so my clinical area is in trauma, and there's actually very good evidence for doing full trauma treatment, including exposure virtually. However, I would say that's in particular, people would need training. So we all know that people get a little, it's probably the area people are most uncomfortable with, even in person, if they don't have training. So I would say, like, if it's a team that's well functioning, has training in translating that treatment into virtual care, trauma-focused cognitive behavioral therapy, for example, and then also, but assessing clients individually. But if there's less comfort, you can do everything else except the exposure treatment. So all like the psychoeducation and the mindfulness and the relaxation, and even some of the cognitive work and validation, all of those things. But the exposure piece would be, I think you need some specific training to do it virtually.
Okay, great. That's really, really helpful. I think one of the other questions we got a lot of interest in is, we're talking sort of about shifting in-person care to a virtual modality, but this is all happening in the context of a pandemic we all know that there are huge impacts on children and youth, particularly those who are experiencing some complex needs. So the question is, how do I help manage the impact of the pandemic on the mental health of children, youth, and families that I support, knowing that these children, youth, and families are experiencing some high needs, complex situations?
So going back to kind of basics, one of the things that has been happening with pandemic, I think people are kind of, the structure in the day is kind of can get easily lost. Even my own structure is kind of, when am I working? When am I not working? Yeah, it's kind of a trickier one. And so encouraging that within the family structure is to kind of have a routine, even if their school is online and they only have certain classes at certain times, to have certain times of the day that people have structured activities. I think the other one is to think about with parents or caregivers is to kind of brainstorm ideas about how to model resilience, right? So we know that children and youth are very kind of responsive or reactive to how their caregivers are doing. And so if caregivers, if they see the caregivers kind of falling apart because they're overwhelmed with so many things, then that can be really distressing to the young person. And so working with parents to kind of find resources to build resilience, or look for ways to demonstrate resilience in front of their children and youth, I think can go a long way as well.
That's great. Thanks. Allison, anything to add?
Yeah, no, just amplifying that idea of access. Like, I think that is, that alone is going to help people. Like, if they are having increased needs, to have, virtual is allowing people access to care.
That's great. That's great. Just on the note, just going back one, I'm going to sort of try and squeeze in the questions where they feel like they fit best. But before we lose the thread on the trauma discussion, there is a question about training opportunities for virtual trauma work. Vivian is asking about that. Is that something that you can sort of, off the top of your head, share with us? Are those things available? If so, where can people find out about them?
Yeah, so a lot of the work has been done, like the research-based work has been done with the VA, so obviously not children, but in the U.S. And I know that the National Traumatic Stress, let me find it and I'll put it in, the U.S. organization. So trauma-focused CBT, which is for children 6 and up, I believe they may have a virtual training available. I'll look it up and put it in the chat if I can find it.
Great. Thanks so much, Allison. And one last question before we shift to the topic of client engagement. Going back to the issue of assessment, if there are written or drawn parts of your assessment required from children, how do you manage that virtually?
Yeah, so my clinical work so my clinic is for people 13 to 24. So we're not doing a lot of, typically drawings are done as part of a younger child assessment. It might be that you're asking them to draw something online and then show it or draw it on a paper in front of them and then show it to the camera. That might be the best. I do a lot of, so when I'm running groups, I used to use the whiteboard a ton, and now it's a bit trickier. I actually now have this overhead camera where I have a whiteboard and stuff like that set up, but I don't think youth are going to have that necessarily at home. So I'm not sure that can happen. If they are, with their caregiver, maybe the caregiver can hold the phone with the camera on it, and so that if you're interested in the process of how they end up drawing, that's another option to kind of think about. Those are some.
So it requires some sort of creative thinking through in the planning stages, it sounds like, right?
I think so, yeah.
Okay, great, terrific. And it looks like Allison has located that training and has that. Thanks so much for putting that in the chat, Allison. Okay, shifting gears a little bit to still within the sort of area of clinical practice, to client engagement. So the question is, how do I engage with children and youth whose family context is really complex and perhaps high risk? Any particular, we know that client engagement is really, really important in therapeutic practice. How do I navigate that?
I do think so. My typical strategies of engaging client, I'm bringing into the online environment. So that involves kind of starting with getting to know the person outside of their mental health context. What do you like to do with your time? What are your strengths? How do you see yourself kind of in? What are your goals? How do you see yourself in 2, 3, 4 years? Right? Thinking about those kind of things that are beyond kind of the mental health condition. And then lots of validation, as I think validation is kind of go-to because I just find it very effective in terms of building rapport and creating that safe space of, look, this is this assessment is about you. You're the person I'm working with. It's not your priorities. Your needs are my priority. It's not actually the needs of your parents or your caregivers that are my priority. It's your needs. And we're still going to work with your caregivers to kind of help you meet your needs and support your needs. And so setting the frame, I think, is a big part of that. All those things could be done in real life, and they could be done virtually as well. And with regards to high risk environments, is having that contingency plan in place ahead of time. That's kind of, as we already talked about, kind of mapped out with your organizations, and communication around having a consistent messaging around what those policies are and communicating them to the client and the families ahead of time.
That's great. Thanks, Darren. Allison, anything to add about client engagement, what that looks like, how that seems different to you, or how we might need to approach that differently virtually versus in person?
For sure. I mean, I think this is one of the hottest areas actually in virtual care right now. You know, everyone's pretty much got their screens on, they know how to turn them on, they know how to take insight, but how do you establish a therapeutic alliance virtually? And if you like all the things that Darren said, I think cover like the big three things that in the initial conception of a therapeutic alliance. You know, one is the bond that you have. The second is the agreement on how you will approach the tasks of therapy. And that now would include virtual. What's the agreement on how you're going to approach, like, just those basic things, like how often are you going to meet and how long are you going to meet for? And, you know, I think one of the challenges around those kind of expectations and boundaries is it's so easy to connect that I think that can challenge some clients that have a hard time setting boundaries. And then that can affect the trust in the relationship. So I think extra attention to when, how long, all those things, and then agreements on goals. And I think that's a good place to get the clients actively involved in, like, what are we aiming to do here? So I think all the tasks of building a therapeutic alliance apply for virtual as well, and some need adaptations. Last thing is, the good news is that clients tend to rate the therapeutic alliance higher than the providers. So there's something about us, like maybe it's because we know what it's usually like in person. It's hard to say. Maybe there's often a generational gap. I don't know. But the research shows patients like they do feel a sense of connection and alliance, even virtually.
That's great. And would you say that that would be true of a group format as well? Anything sort of unique about establishing therapeutic alliance in a group that people should be aware of?
Actually, Darren would be.
Yeah. So, I mean, my experience again has been a variable, right? So I have my DBT group who are very cohesive and very, very engaged with each other and feeding off each other's, building on each other's ideas and stuff, which has been really amazing. And then I have my other group, which is kind of a bit quieter, a bit more reserved, a bit more pulled back, which I think if they were here in real life, they would probably be a bit more engaged. And the culture might shift. So both these groups are rolling entry groups. So 8 weeks from now, it might shift. So the DBT group might be harder, and then the CBT one is a bit easier. So it does matter. I think it's helpful to kind of keep that in mind, to kind of stick it through and don't just give up if you're kind of like feeling like you're pulling teeth or anything like that in the process.
Great. Okay. I think a number of the other questions that were asked around sort of engagement were related also to support. So supporting young people and families to actually use the virtual care. One of the questions that is that people have posed is, what are the best ways to support the children, youth, and families as they use virtual care? So I think it's about navigating the virtual sort of world. Anything unique about sort of any additional kinds of supports? I mean, I feel like you folks have also talked quite a bit about preparation, the importance of preparation, the importance of contingency planning, the importance of sort of getting ready to be prepared for whatever ends up sort of rolling out in the session. Anything else that you would say about the best ways to support children, youth, and families as they're using virtual care? Allison, maybe we'll start with you on this one.
Sure. So in my head, I just had like a continuum. So I think on the kind of preparation, the lighter end of the continuum involving youth and families. Like, I think we're all learning that now, that the need as we move forward and sustain these services to involve youth and families in designing them and developing them, and that will help a lot. And then once we're like into the session, preparing, not just preparing, but I know some organizations that are actually doing digital literacy type workshops or orientations for clients before their appointments. So like more formal preparation of clients using peer supports. I think that there's going to be some really neat opportunities there as we go forward. So if you can't be with the client in person, are there peer supports who can, partnering with a local CMHA, for example.
Right.
And then on the extreme end, one thing that I meant to bring up earlier and didn't come up is, I do think we have to be careful. Like, so we know that some of the challenges and the equity issues and the safety issues that are involved with calling police. So, I mean, I don't want to be too controversial, but I think it is something that we have to think about in the kind of responder community. We talk about active rescues, and like that has to be a very extreme measure. And we have to think about what that would be like, that we wouldn't physically be there if someone has to come into the client's home. It's going to be very, very rare. But so having, are there other steps you can take before that? So making things safe in that way, I think having some forethought about that is important.
That's great. I mean, one of the other questions that's related to this, Allison, which I think is an important one, is how do you handle negative and challenging parental involvement, or challenging when external disruptions are coming in, whether it's from the parent or whether it's from someone else, if there's signs of danger, that sort of thing, how do you respond to those?
It's definitely a question for Darren.
Yeah, I haven't had, so just as Allison was saying, it's pretty rare. Like, I have not had to call the police during any of these appointments. The one instance where I had to use a contingency plan, I called the mother. There's a patient I knew very well, and I knew that sometimes they get distressed. Even if I couldn't reach the parent, I was kind of feeling okay with things, right? It's pretty rare that we have to get to that level, which I think is important to kind of keep in mind. I do think I know that safety issues can cause a lot of anxiety in us, right? And sometimes we do want to respond in an emergency way, but having kind of a thoughtful process, talking to colleagues and saying, hey, this is going on. Do you have ideas about what I can do? So it's not an impulsive reaction, I think is
right.
important. Because in the attempt to try and keep things safe, it might make things less safe, right? And so I think in the end, you have to kind of balance that potential pros and cons, and go from there.
Okay, great. Another topic that had come up around this area of engagement and support is around exhaustion. So, young people are often, many young people are in school online. Some people are working online. How do you support young people who may already be super exhausted by lots and lots of screen time to actually engage in virtual care?
So I think it's helpful to kind of at the outset ask them, how long have you been on screen today? Get a sense of where that's going. What's school like for you when it's online? How much time do you have? Do you feel tired from the day? So kind of rather than guessing that they're feeling tired, I think it's helpful to kind of actually ask them. I think it has come up in our CBT group in terms of kind of, we know that their attention seems to be waning after about 45 minutes to an hour, which I think to me makes total sense if they've been in school all day. Having breaks in the middle might be something to think about. Our DBT group's a bit longer. It's 2 hours. We have a 10-minute break in the middle where I just say, get up, move around, go to the washroom, get a snack. And it does seem to keep people engaged. And so that's another option as well.
Great.
Yeah.
Okay, that's helpful. Allison, anything to add to that?
Yeah,
how do you deal with it? I know you have been also dealing with kids at home and lots and lots of screen time. How do you encourage young people to feel engaged in therapy virtually if they've already spent umpteen hours online?
It's so true. And I was just thinking about what you were saying, Darren. And I know with some of my kids, yeah, with the multitudes I have, no, with one of my kids, he doesn't know when he's done with screens. It's like, it's his behavior that starts going. So I guess with younger kids, like enlisting parents to kind of check in on that, and also choice. You know, I know in my own, I do long-term psychoanalysis as an analyst, and I know, like, there are sometimes I say to my analysts, like, could we do a phone session, or can I walk while I talk to you? Because I just can't bear to be, you know, face on in the screen. So I think choice and checking in, as Darren said, and maybe using parents too, if you're not sure.
It sounds like a flexible approach is necessary one way or another in this sort of area, right? Okay. The last question that I'll ask in this sort of clinical sort of area is around uptake of virtual care. So despite putting everything in place, despite the fact that the research says that for young people, this is like they actually really like engaging with a therapist virtually, what do you do in cases where young people really just do not feel like it's a good fit for their needs? Are there any strategies people can use, or do you sort of reserve a small portion of your practice for those in person? And Darren, I'm remembering what you said earlier on about how one young person, you know, that's their preference, and wanting to, you suit up, you get in person, you do what you need to do in order to see them. But are there other ways of sort of moving people away from that feeling of this isn't really right for me, and I'll wait until I can have an in-person session?
Yeah, I think if there's an opportunity to assess what's behind that hesitation, I think that can be really helpful. We've found that some youth actually, the main thing is that they don't like seeing themselves on camera, and just teaching them that you can turn off your own self view is enough of a comfort thing that they're able to proceed. It might be that I'm only seeing them on camera for the first 5 minutes, and then after that it's by phone, by voice only. Again, that carries with it some risk, but I'm actually getting more comfortable with that as time goes on as well. So those are some thoughts. We have run into that where there was a wait list developing for people who refused to do online. And so I'm not sure if that wait list is still there or not, but it's something to be thoughtful of as well. For myself, I certainly, if someone's refusing, I would see them in person and try eventually to get them to do online, because again, it is a bit more efficient and safe in terms of infections and things like that. But I will accommodate them. We haven't had to in our clinic with the older youth at this point. So yeah.
Okay, great. Anything to add, Allison?
You know what I meant to say earlier, we talked about trauma interventions, but being trauma informed is sort of that general policy comes to mind here, that sometimes we don't know, and sometimes even clients don't know why they're not comfortable with different things, and that we also have to think about that virtually. Like, maybe people are uncomfortable if they can't feel your presence. Or, I mean, I had a client who we had a connection challenge, and the call got dropped, and she was panic stricken, because for her, disconnection has a much more loaded meaning than just the actual technical connection.
Right.
So I think being trauma informed and recognizing, you know, some people may have had trauma that's directly online, like online bullying or something like trafficking in extreme cases. So that would be an extreme, but then other people, it's just the adverse experiences that they've had make the virtual environment feel unsafe or feel less connected. And so, yeah, being open, I think we do have to, when we can, offer the option of in-person.
Okay, great. So that seems to be the theme around the clinical considerations. Really trust yourself as a clinician to know what to do, and make sure you're really well prepared, and that you've done your planning, and that if things do go sideways, that you are flexible in your approach. So let's shift gears a little bit to some of the organizational considerations that we should keep in mind when, as a service agency, we're putting virtual care in place for young people with high risk and complex kinds of needs. One of the first questions that people had was, how do I minimize cancellations and no-shows when as an organization, you reserve time, you schedule appropriately, and so on. How do you sort of make sure that people are actually attending sessions, and that no-shows are going to stay down?
So in our situation, there's a few strategies we've used. So we do have the resources where the administrative support will call them the day before, which actually makes a huge difference in terms of rates of no-shows. The other is just with the link. So we use WebEx at CAMH, and we can actually just send the link. Again, it's pretty easy in our calendar just to go, okay, send it and they get an email reminder just through that process. We've had with this opportunity to call people and just say, hey, we noticed you're not at your appointment. If they're not there 5 minutes in, anything getting in the way, half of the time they're, oh no, I just forgot, or I just woke up, or something happened like that, where I'm actually seeing fewer no-shows as a result of that. So those are some of the strategies I've used. One of the things, so I work with, again, young people with concurrent disorders whose lives are often very chaotic. And sometimes we do have people who just are not able to attend appointments. This is my own arrangement. I don't think other people necessarily do this in our clinic, but I do have like a 1 o'clock drop-in time that they can go to my personal room on WebEx at 1 o'clock, and they'll wait in the waiting room until I have space between other clients, and I'll see them for 5-10 minutes if they've missed their appointment or something like that. And that flexibility seems to be appreciated as well, certainly for some of my clients who have a bit more chaotic lifestyles.
So a quick check-in is helpful if a full session isn't possible. It's
great. frequent quick check-ins work well. Yeah.
That's great. Allison, strategies you've used to manage no-shows and missed appointments?
So again, it would be more on the administrative side. And I agree with what Darren's saying, just about having a plan. And this is where administrative support and thinking organizationally about how virtual care is going to fit in is so important, because I think a lot of these tasks can be done by the people who are administering and managing the virtual care service. And it improved our no-show rate by 25%
wow.
when we introduced some of these measures of like calling ahead of time, etc.
That's great. I mean, in another webinar that we did with really little guys and supports for, it was a presentation during the CMHO conference, the presenter was talking about how her no-shows have gone to zero. So the fact that families don't have to actually travel, and these are families that have small children, and sort of the all of the logistics and pragmatics that go with getting from point A to point B, they were all removed, so you could actually see the person in the home. So no-shows generally, because of the modality, seem to be decreasing. So everybody's favorite topic, technical difficulties. I feel like we've all sort of worked out many of these bugs. I personally had a microphone that didn't work for the first 6 months of the pandemic. And so now all of that's taken care of. But when these things do crop up, because we don't have, seamless systems all the time, how do I manage technical difficulties during the delivery of high risk care for complex kids?
I think that having familiarity with the program that you're using is a really important. So within WebEx, we have the option that if it's cutting in and out, then there's the option for the patient to call in on their phone, and it still goes through WebEx. And maybe I can see them through the video on WebEx, but their voice is at least smooth and things like that. So there's that option. Sometimes we're doing video, but the audios through the proper phone line. So there's all sorts of kind of creative workarounds that we've been using. Ultimately, I have clients who it's just not worked out. They don't have the technology or bandwidth or what have you. And so we're doing phone check-ins and getting comfort with that has been, so far it's been actually really good in terms of keeping check-ins on people, frequent check-ins on people who don't have resources. And so that's been developing comfort level as well.
That's great. So having an alternative in the event that the technology isn't working, really important. Again, part of that contingency planning, right? You know, and again, sort of around the idea of particular sort of getting to know a particular platform. How do you actually pick that platform? So I know CAMH uses WebEx. What about, you know, Zoom or Blue Jeans, or there are a whole bunch of different platforms. Allison, can you comment on how do you pick the right platform for your organization?
Sometimes it's out of your control, but I do think there, you know, to protect all of us, it makes sense to have an organizational vetting process and to use a single, if possible, technology or a small suite of technologies, because this is going to pertain a lot to like our steady state and sustaining virtual care, because there are considerations. So security is the number one consideration. Whether it is HIPAA compliant, you know, whether data goes into the US, for example. I know people, like I love Zoom. It's very adaptable and it's good. There's good picture and so on. And now there's Zoom Health. So like within a particular platform, what level of security you use. And I know that's why we went with WebEx, because early on, they were able to have that high degree of security. That's the number one consideration. But then there are things like interoperability, like what other electronic systems is your hospital using, and is that the one that functions best? And yeah, just the longevity, you know, choosing some of these smaller things is probably not, who knows if they'll be around in a couple of years.
Right. And that's really helpful, just to sort of the advice to make sure your organization has one, right? Because it's helpful also when you're doing clinical or peer support as clinicians, right? Clinical supervision and so on, to get familiar with and comfortable with using that one technology. Early on in the pandemic, we had found one of our colleagues in one of the child and youth mental health agencies had actually created a table, which was super helpful. And it actually compared all of the different platforms on a number of different dimensions. And Greg is putting into the chat that unfortunately price is one of those dimensions. And so sometimes the cheapest option ends up being the preferred one, and bandwidth as well. So really, really important as you consider which type of platform. At an organizational level, one of the big questions and concerns, and I think we're all sort of aware of this as a concern, is around burnout. So we are now literally getting to 1 year, the 1 year anniversary of this pandemic having begun, and all of the shifts that have happened, and the adrenaline is now gone, because that sort of sustained many of us for the first part of the pandemic. How do we prevent burnout among our clinicians as they themselves are providing really intensive services to kids with complex needs?
Great question. So I think my number one thing that has helped me prevent burnout is staff-to-staff consultation. So we do a DBT-like consultation model where every 2 weeks the clinicians get together and talk about cases that they're struggling with. We also express to each other how much we're burning out, how much do we feel ineffective, what are some ways to work around it, and we do lots of validating each other in that process as well, and also kind of ideas about problem solving on how to reduce the burnout, because ultimately that we're hoping for that. And we've had I work with some great people who are that's been a huge component of me being able to sustain the work I do. So having that community of practice is a big component. I think it's also important to kind of, right now, people are hesitant to take vacations because there's nowhere to go. And so important to set aside that time and carve that time out for downtime so that you're not constantly going, I think is another important component to keep in mind during these times.
That's great. Allison, how are you managing, or how are you and your peers managing to avoid burnout and among one another? How are you supporting each other to do that?
sometimes it feels like we are hanging on by our fingernails, and it seems to fluctuate across the team, fortunately, because I agree, team, like having that team support, I really feel for solo practitioners right now, because I think that must be an added burden. I just posted in the chat a piece that I did for Healthy Debate on what we call digital compassion. And I think digital compassion really extends to self-care and some tips for self-care. I have found mindfulness. I know everyone pounds the mindfulness, but I have found it very helpful. And just doing even just a minute or two of that kind of reframing, refreshing. So much of virtual care leaves our bodies behind. And so to just reconnect before I go into another Zoom space, I find really helpful. And even in our ECHO programs, which is a virtual community of practice, we have integrated mindfulness into all of our sessions, and we get like pretty great feedback on just doing that and taking that time.
That's great. That's great. Very, very helpful. I had seen that article, and I know from having read it that it's quite helpful, even for those of us that don't deliver virtual care. Just as people that are interacting hugely on these kinds of modalities. Shifting a little bit to professional and legal requirements, a bit of the pragmatics. I know we started off early on talking about, getting consent, talking about privacy and so on. How do you collect informed consent virtually? I think this is a really practical question.
I was waiting for Allison, and Allison's waiting for me.
We're also polite, right?
You know what?
I'm trying not to call on anybody.
Sometimes we collect it with a real headache. Okay, so you can obtain the consent verbally. Technically, you should, if you're doing the assessment, you should get the consent. Some people have delegated it to an administrator ahead of time, but really technically, I should be checking that the person I'm about to speak to consents to speaking with me virtually. And then there's the documentation. That's where it's like a bit of a pain, especially if you're working home, whether you use physical charting or electronic health records, it should be documented in the person's chart that they have consented. Those are the two. And so we've also developed scripts for people, just so that you're not trying to remember every element, right. So like a standard script, and a template in our electronic health record. So you can just go, yes, consent obtained, and a thing will be generated, text will be generated.
That's great.
Yeah, I think being aware of the potential adverse outcomes that could happen, and being able to list those, particularly the main one is that we can't guarantee this information will be intercepted through any electronic communication. And so right. That's the big one to kind of make sure they're aware of, that there might be some sort of privacy breach, despite our best intentions. Yeah.
Okay. Great. Terrific. I think that the other questions around this were around privacy, confidentiality, and I think you folks had addressed that really well earlier on in the discussion. I'd like to move now to system level considerations. One of the things that is, an important piece around care broadly is to make sure that care is delivered consistently across our entire system, and that it doesn't matter where you live in the system as a young person, that you have the same access to high quality care. Are there any examples of community partners that are working together to try and ensure this consistency, or collaborating to deliver virtual care together to complex young people?
Examples, Darren?
So this is where I can bring in my study, maybe. So
this is a really nice cue.
Yeah, sure. So the study that we're hoping to launch, or right now we have funding to launch, a study of an integrated care pathway in the community mental health agencies for youth with depression. And the pathway involves a structured approach to assessment, education, psychotherapy options, medication options, family support, and discharge, appropriate discharge. It's all based on the NICE guidelines for depression. And so we're hoping to do that. And through that process, we are also hoping to build a community of practice as well, so that different mental health agencies can support each other in the work that they're doing. And the integrated care pathway is also intended to be flexible in that it can be delivered in real life as well as online. So that's one potential opportunity in the future to look for ways to have a successful community partners working together for virtual care. And if you're interested in knowing more about that, I'm not sure who the best person, so I can put my email in the chat and go from there. And certainly Tracy can forward my email if anyone doesn't quite capture my email here.
That's great. That's
Are
great.
there gift certificates?
Gift certificates. So for people joining our study,
yeah.
Well, there's lots of benefits. There's lots of tons of benefits.
All the benefits, so, I know. So. I want the gift certificate. I want like the gas card or the.
I can give you a $5 Starbucks card if you like. We have to follow the Research Ethics Board's protocols. That's
okay. I think so. I was involved. There were a lot of us involved in this. What are they called? RSC. The Royal Society of Canada did a report on COVID-19 and mental health. But one of the big areas of focus was virtual care. And I think one of the most pressing things going forward is integration. You know, we've all made space to see people individually. But if they just end up with a bunch of silos of care, and especially for this kind of population, like high risk care, what are the transitions in care? What's the continuity of care? What is team-based care? What kind of models are we using? You know, how is it integrated into our healthcare system? I think these are all what's going to make or break. You know, will we go back to less than 1% of care virtually, which it was before the pandemic, or will we be able to sustain this 40 to 50% virtual care? It's going to depend on like how well it fits into our system.
Very true. And I know that that's part of in the community-based child and youth mental health sector right now, part of the thinking around, you know, the suite of services and what proportion is going to be in person, what proportion is going to be virtual, what proportion is going to be mixed. I think child and youth mental health agency leaders are spending a lot of time thinking about that. So very, very helpful. Shifting now to our last area around the evidence. So to your point, Allison, around the 1% of care used to be delivered virtually. So there was a very kind of focused and discrete, rich, but focused and discrete sort of body of evidence related to virtual care delivery and all of the aspects of it. Our observation in sort of trying to capture some of this evidence is that it is not plentiful, first of all, but it also requires a bit of time, right? So right now people are doing lots of work in the area. It's been a ripe kind of time for people to do research on virtual care. And so people are curious about what the evidence is starting to say. So one of the questions that folks had was around, what are you seeing as the current mental health trends across different age groups when it comes to high-risk virtual care? When you're thinking about the evidence for virtual care delivery, are you seeing any trends? Is it working well for some particular populations better than others?
Go ahead, Allison. Yeah.
Oh yeah, did I do that lane for? Immediately, I think health equity. So digital health equity, I think, has been pretty much a rallying cry. So many people have realized that people who have the wherewithal and the resources and so on to get onto care, got onto care very early virtually, and there are a lot of groups left behind. So I think, and across all, when we looked at the data at CYMH, really any equity factor showed up in the data. So age, language, income, housing, ethnicity, disability, there were gaps across all of the health equity factors. So I think that is a big area of interest going forward.
Yeah, and I know that there's a lot of studies that are initiated in terms of studying this. So one opportunity we were collecting pre-post scores on our DBT groups before COVID, and now we're doing it all virtually. We're doing the same pre-post scores. And so we'll be able to kind of see, are we getting the same outcomes or not? Which will be really interesting. It's too early to collect and analyze that data right now, but that's something we look forward to. And I know there's lots of other groups doing very similar things. I anticipate in the next 2-3 years, we're going to see a lot of data coming out and a lot of information, because everyone has made that switch, and doing a similar study would be very easy to do. So
yeah, for sure. For sure. And we have done some work to evaluate the effectiveness of virtual care or the experience of transitioning to virtual care across the sector. And so one of the things we've been doing at the center, again, center plug, we actually have a brief that can help organizations to evaluate virtual care delivery. And I know, Allison, you are very, very involved in the creation of one of the tools that we're promoting, the Virtual Care Experience Survey. The idea is that it's important as an organization to understand once you're making these decisions about, what proportion of your services are going to be virtual versus in person, you need to have some evidence behind them around how well these services are working for families, as well as the service providers delivering them. So we have one brief looking at, and I think Tracy's going to be putting a couple of links into the chat box. One of them is that comparison of modalities. But if we're also able to find, Tracy, the link to the how do you evaluate virtual care, that could be a really helpful, it doesn't give you sort of all of the answers. It basically says these are the kinds of questions you'll want to be asking yourselves as an organization as you're delivering virtual care. We also have on our website a summary of our own evaluation of the sector's transition to virtual care. So knowing that we all pivoted very, very quickly, all service delivery agencies pivoted quickly, there's lots to learn about how, when we can take a breath and when we can implement with a bit more sort of time, what are the things we need to keep in mind around implementing virtual care in an ongoing sort of longer term way. So just a couple of, thank you so much, Tracy, for finding those for me. Tracy's put them in the chat for folks that are interested. But again, really, really important that people are gathering information and sharing it right now. And I would imagine that there's going to be a real explosion of evidence in this area over the next couple of years at least. So I'm going to pause there. We have about 8 minutes left, and I'm going to ask Darren and Allison, this has been such an incredible and rich discussion. I want to thank you both for sharing all of your wisdom with us here today. Any final thoughts? And I would also, while that's happening, encourage people, if you have any last minute questions, please do feel free to use the chat. But Darren, maybe I'll start with you. Do you have any final thoughts you want to share with folks?
Yeah, first of all, thanks for having me here. It's been a great pleasure, and love the discussion myself. The main thing I think is I think it's important, if you do have some hesitancy around virtual care, to try it out, try things out, because as experience has been going, it's been a very positive experience from my end. That I really do think that the risk of not seeing someone far outweighs the risks of doing virtual care. We know that from a study in England, that youth with depression, if they had any contact with the mental health system, they did much better than if they didn't have contact with the mental health system. And so maintaining that contact and doing follow-up is really an important part. And I would just advocate for people to engage with it and learn about it, get used to it, and enjoy it because it has lots of potential benefits.
That's great. And I think through the conversation today, you both have been so excellent at demystifying some of those things that feel like big barriers or feel like big challenges. That just try it is a really, really good, really good piece of advice. Allison, any final thoughts from you?
I agree with everything Darren has said. And, yeah, just try it, just embrace it, just do it. I've always been shocked at how behind really as a field we are in incorporating technology. Like these are not revolutionary technologies at this point. It's video conferencing. If you do it with your grandmother, you can do it with your patients. I think this area has been so driven by providers. That's the other thing I would say. We need to shift to thinking about the experiences, the needs of patients and families and communities. We haven't talked much about communities. I think that's another area that needs developed. When we did a study back in 2017, looking at how virtual care is delivered in the province, it looked ridiculous. Yeah. We need to think about that system, but also with the view to not passing over communities and passing over the way that they want to organize their health services. So I think giving more thought to that health system piece is also, and keeping the patient and family at the center, more person-centered virtual care.
That's great. That's great. Well, I know that if I were a clinician, and I'm not a clinician, but if I were a clinician, I'd feel ready to go at this point. You both have shared so much excellent advice, and your wisdom is so appreciated. So thanks to you both for sharing your time with us today and your experiences and expertise. And thanks to everybody that joined us this afternoon. We hope that you enjoyed the conversation as much as we did. And I want to thank Tracy McLaurin for all of the coordination and keeping everything going so that we could deliver this session for you. I'll just remind folks that there are a number of links in the chat, and this will be recorded. This has been recorded and will be up on our website at cymh.ca. So please feel free to visit our website for the recording of this session, but also all of the webinars that we have delivered throughout the course of the pandemic. And also just a final plug, please do feel free to fill in the evaluation that will be in your inbox. We're really, really eager to hear what you think and eager to hear about additional ideas for webinars, but also any kind of evidence support that you feel would be helpful as you move through these hopefully last stages of the pandemic and post-pandemic. And we're very, very eager to continue to support you through this. So thanks very much, everyone. And I will wish you a great rest of your day and a terrific weekend. Thanks all.